presentation, which is on necrotizing myopathies, is I'm just going to talk for maybe a couple minutes, just to sort of give you what my background spiel on necrotizing myopathies is, and then really I consider this to be a question-answer session. I'm here at your disposal to answer any questions that you may have. And what I would start off by saying is that maybe 5 or 10 years ago, when we thought about myositis, we kind of thought about there being 3 different kinds of myositis. We thought there's inclusion body myositis, and you've seen probably a lot of patients around here who have inclusion body myositis. We thought there was dermatomyositis, and then we thought there's polymyositis. And we thought that there are really 3 different kinds of muscle biopsy features you could see. You could see patients with inclusion body myositis had inflammation and rimmed vacuoles on their muscle biopsies, and that's what defined them as being inclusion body myositis. Patients with dermatomyositis, you could look at their muscle biopsies. They had something called perifascicular atrophy, which was very just typical for dermatomyositis. And then we said patients with polymyositis had lots of inflammatory cells in their muscle biopsy, and some of those inflammatory cells were surrounding and invading otherwise healthy, normal-looking muscle fibers. And really, it's come to our attention that there's another category of autoimmune muscle disease that we can think of based on the muscle biopsy features, where there's very little in the way of inflammation. There might be some, but usually it's pretty scanty, but lots of muscle fiber death, right? So the muscle fibers are dying, they're necrotic. Dying and necrotic mean exactly the same thing, and but very little inflammation. So we called those necrotizing muscle biopsies, so that patients who have autoimmune muscle disease, who have a necrotizing muscle biopsy, we call that immune-mediated, or another word for autoimmune. Some people call it autoimmune necrotizing myositis or necrotizing myopathy. So that's how we think about it from a muscle biopsy point of view, right? When we look at the muscle biopsies. But it turns out that there's not just one flavor of immune-mediated necrotizing myopathy, and I think of them in 3 major categories. One would be if you have, and they're all based on what autoantibody you have, okay? So patients with autoantibodies recognizing SRP, or the signal recognition particle, that's one group of patients, and they are different from the other ones who have immune-mediated necrotizing myopathy. There's another group of autoantibodies that recognize HMG-CoA reductase, or HMGCR. Their muscle biopsies look the same. You can't tell them apart from the SRP patients, but their clinical features are different, probably different diseases. And then you have patients, then you have everybody else, okay? And some of them, we just maybe haven't found the autoantibody. Some of them, you might just miss the inflammation on biopsy because maybe you just hit a place where there wasn't inflammation, but there was necrosis, or maybe they have an overlap with some other disease. And then it just turns out some patients who have other forms of myositis, like dermatomyositis, when you do their biopsy, it could be mostly necrotic. But when I say immune-mediated necrotizing myopathy, I'm really talking about, because this is what I understand, I'm talking about the people who have either anti-SRP autoantibodies or HMGCR autoantibodies. And I prefer to talk really about those as separate things, because they have separate risk factors, they respond differently to different treatments, and they're probably different diseases. So that's sort of in a nutshell, just to sort of give you a historical background where we are, how we think about the different categories. But necrotizing is either SRP or HMGCR, we don't know. And the other thing I would say is that there's some commonalities between SRP and HMGCR. One of those is that the younger you are when you get it, in general, we think, the worse it is. So this is particularly true with SRP, for sure. SRP patients, the younger they are when they get the disease, the more likely, it's not that none of them get better, but the less likely it is. And the older patients are among the patients who do the best. So our older SRP patients, some of them are very mild. And the same can be said for HMGCR. Our older patients, and this is patients who get treated relatively early, right? Because if you've had the disease for a long time, you can have muscle damage. But if you get recognized early and treated early, the older anti-HMGCR patients tend to do better as well, at least in our cohort, the ones that we've studied, which is adults. I'm not really speaking to childhood myositis, which may be different, just to make it more complicated. The other thing I would say, as a generality, is that we think that anti-SRP patients are very likely to respond to rituximab. That for some patients is the magic bullet. Sometimes it requires other medications on top of rituximab, and rituximab doesn't work for everyone. But in our clinic, at least, when we see someone has anti-SRP myopathy, we're going to rituximab right away because we've had so much luck with it, and we don't want to wait 3 years to get to that point. We want to treat it early. And in patients who have anti-HMGCR, we like IVIG as sort of our first line therapy. I've treated a lot of patients with just IVIG from day one, and that tends to work well in most of those patients.
Stephen's getting that as a monotherapy.
Yeah.
And many of the doctors have said, no, that's wrong.
Yeah.
Not,
Well, I think the proof is in the pudding. You know, if you get IVIG as monotherapy and it's working for you, it by definition is working. You know, everybody's different. You know, there's not one answer. But I use it and almost everybody, I use it as monotherapy right out of the gate. But I was a little bit of a rogue kind of guy in doing that at the beginning. But now more and more people do it. And I can tell you the reason why I did it. The reason why I did it is because I'd have patients who come in, I treat them with 60 milligrams of prednisone and methotrexate for 3 months, and I would get very little response. And then I'd start IVIG, and boom, they'd start to get better. And so I had 2 or 3 patients who came who had never been treated with anything else and were pretty weak, and they had anti-HMGCR, and they had diabetes or some other reason they didn't really want to go on the steroids. So I said, well, how about if we just try IVIG as monotherapy? And for all 3 of those patients, they all were much better within 1 to 3 months.
Better being better CK.
Stronger.
Not CKs.
CKs also went down, but at the here's a good thing.
But does that cover the waterfront?
So, unlike most other forms of myositis, I actually care about the CK in the necrotizing myopathies. So this is different than if you just were here for my IBM lecture, I told them, I don't even check your CK because it doesn't matter to me. But in anti-HMGCR and anti-SRP, because it's a necrotizing myopathy and necrosis causes the muscle cells to break open and leak the CK out, I do use CK to help me know what's going on. Now, but it's complicated because some patients get all the way better in terms of muscle strength, but still have a pretty high CK. So I have a couple patients walking around with CKs of 1 to 2,000. They were 10,000, now they're 1 to 2,000. They feel fine. They're doing everything that they want to be doing. They're not weak on my exam. I think they still have some active disease because the CK is elevated, but I don't necessarily treat them harder to make the CK come down if they're fully strong.
he's got the opposite situation. His CK's down to 500, but he doesn't feel better.
Yeah, so what did the CK start at?
1,800.
So CK started at 1,800, now it's up to 500. How over what period of time?
He's been on 3 courses of IVIG, 3 months.
You're still early.
Yeah.
Or 3 months is still early. If the CK is coming down, that's good news. It's a third of what it used to be. And what we would expect is it takes a while for some people to regenerate muscle and start getting stronger. The other thing that I don't know about you is, how long did you have it before you got treated? Some patients, if they've had it, particularly if they've had it for a long time, can develop some permanent muscle damage that I can't make better. And if you have a question, am I just not getting any better because I can't get any better? Or should I push harder on the immunosuppression? You can do an MRI of the muscle, and the MRI will tell you how much permanent damage was done to the muscle, how much current activity there is. But generally, in patients who are still weak, who have SRP or HMGCR, if their CK is elevated, I'm going to push more. on the therapy. But the main thing is whether you're getting stronger or not. So like, let me ask you a question. So when you were at your weakest, could you get up out of a chair without using your arms?
Yes, at my weakest,
Yeah.
I believe so.
What did you have trouble doing when you were at your weakest?
He would fall and not be able to get up.
Is that still happening?
Not falling, but tripping,
Yeah.
getting out of balance and recovering.
Is that better?
No.
No. So so I can't answer it that easily for you. But what I would say is 3 months is too early for me to know. 6 months usually by 3 or 4 months I know. And the other thing is I have some patients who can't tell that they're getting stronger by quantitatively measure their muscle strength. It's like, no, you're getting stronger. The opposite happens to some people. They're like, this is great, this drug is working, and I'm like, no, it's not. So at the end of the day, I'm depending on my exam to figure out whether people are getting better or not.
So you think
But
six-
if IVIG, but I'm not like trying to sell IVIG as the final solution for everybody. It may be that something else will work for you. It's all in every kind of myositis. It's trial and error. There's no one size fits all for these drugs. Unfortunately, we don't know why that is. So if I saw you in another month and I actually didn't think you were getting any better and your CK was still high, I might add something else on. But it sounds like IVIG is doing something.
So 6 months is reasonable for monotherapy.
There's no right answer to that. Yeah, it's very highly individualized. Yeah. Question in the back.
Yes, doctor, I have a severe case of calcinosis
Yep,
with dermatomyositis.
yep,
My strength is really good, my strength levels. My CK is marginal, medium to high, probably in the mid-200s. It's really not bad, and it's always been consistently high. As a matter of fact, when it's been low, I felt terrible.
the CK?
Yeah,
Yeah.
CK, but it's good.
But you have dermatomyositis, is that right?
Dermatomyositis.
So so everything I've said doesn't apply to you.
Okay.
So dermatomyositis is a different disease than what I'm talking about.
But because of the chronic calcinosis.
Yep,
And the way the tissue appears around any area that has the calcium,
yep,
which appears to die,
yep.
and it almost turns black, really. And it really looks necrotic. Are they sure?
So you can have, what I would say about dermatomyositis is, so you can have necrotic skin,
Yeah,
right?
okay.
And you can actually have necrosis in your muscle biopsy.
Mhm.
And 15% of dermatomyositis muscle biopsies in our cohort are predominantly necrotizing muscle biopsies.
Okay,
But if you don't have SRP or HMG-CR autoantibodies, which most people with dermatomyositis do not have, then even though there's a lot of necrosis on the muscle biopsy, I still think of that as a separate disease, and I don't think of the things I just said applying. So for example, in dermatomyositis, people can have very severe flares of their muscle disease without their CK going up. And a common mistake in that disease is the doctor's just watching the CK,
right,
and that's not the right approach in dermatomyositis.
okay.
So you're welcome to stay here, but I just want to make sure you understand, like, the things I'm saying may not be appropriate for somebody with dermatomyositis.
Right, I understood.
Yeah,
I also have another question.
Sure.
Which may or may not be related. Did a DNA test,
yeah.
and it came back that there was some genetic relative who was an Ashkenazi Jew.
Oh, yeah, yeah.
Is there any relationship between that and the myositis families?
That's a great question about, so Ashkenazi Jews do have predisposition to certain diseases. To the best of my knowledge, not myositis. I've never heard of that. I can't swear it's not true, not dermatomyositis. There are certain genetic factors that contribute to dermatomyositis, but I don't think that the Ashkenazi Jewish population carries those. Most of what they have are just genes in their population that cause different types of genetic disease, and some of them are genetic muscle diseases, but not dermatomyositis. Yeah.
Thank you.
I would, yeah, and then there are differences in how well people do based on their age, based on their gender, and based on race.
Okay.
So all those things are important, and for example, are young black women with SRP and HMGCR are some of the most difficult to treat patients that we have, and we don't know why that is. But so all those things do play into it somehow.
Well, I'm
Yeah.
63, so.
So you're
I'm
still young. You're still young. Yeah. Other questions? Yes.
If I have anti-SRP,
Yeah.
is that something you develop? Is it something that's part of your DNA from when you're born?
Oh.
How do you get to
I
the
wish I
anti-SRP?
knew when people develop anti-SRP autoantibodies. So the problem is hardly anybody has blood drawn before they get sick. Not that's stored away somewhere where you could test.
Right, just
right?
like Red Cross, and they
So-
don't look for that.
What little we know about this, we know from, I believe it's lupus that they studied. So people were interested in this. Do the autoantibodies come first or do they come later? And it turns out the military collects blood samples on all the personnel, right, that they have, and they collect it when they recruit, and then they keep collecting blood, and they have incredible medical records. And so somebody, I forgot who it was, they were able to go back and get the blood samples from people who did and did not develop lupus, and they were able to look way, way before people developed lupus and see, when did the antibodies come? And it turned out the antibodies started way before the disease. They didn't necessarily have them at birth, but they pop up and they precede the development of the clinical manifestations of the disease. So I don't know for sure when people's antibodies develop, but I think it's before the disease manifestations in most cases. We haven't done this as carefully as we could. It's a great study. So we have a bunch of patients where they have no known autoantibodies, but we do all the testing when they first show up. What we've never done is gone back and say, let's look at their blood from when we saw them last week. So we could compare. Just give you an idea. Maybe we'll get a publication. You could be a co-author.
You have my blood.
Yeah.
You see Dr.
Be a co-author.
Tianko.
You see Tianko? Okay, great. So we could do that. We could take all our first blood samples where there's no autoantibody, and then our more recent ones that we collected over the last 10 years and see, did anybody develop autoantibodies? But that's a great idea, but we don't have your blood going back, so I can't answer it.
Because the question I'm always asked
Yeah.
is, I got diagnosed when I was 43, and I'm 49 now. The question I'm always asked is, did you get sick? Did you have a virus? And I had like a whopping bad case of mono, but way back when I was like 19, and they're like, that's too long ago.
Who knows?
But
Yeah, I don't know. Nobody knows. Nobody knows. The only thing that we do know for sure is that statins are a risk factor for developing anti-HMGCR myopathy. Not everyone has statin exposure, and the other thing I'll tell you is not everybody knows they had statin exposure. So I have now 2 patients so I'll tell you the one story. So a guy comes to me when I first started seeing myositis patients, and he has a necrotizing myopathy, responded to IVIG, and he was like, this all started when I was taking mushroom extracts. I was taking them for months, I was taking a few pills every day, and I developed weakness, I stopped taking them, and now here I am years later, I still have some active muscle disease, and could the mushroom extracts have done this? And I was like, no, there's no way. If you took them so long ago, and probably they weren't toxic to begin with, but even if they were toxic, you stopped it, and now you still have this active disease. So I don't think that has anything to do with it. So years go by, we discover the anti-HMGCR autoantibodies, and we go back and test his blood. And lo and behold, he's positive for anti-HMGCR autoantibodies. So I tracked him down, and I was like, what was that, that dietary supplement you're taking? He still had the bottle, and the number one ingredient was a type of mushroom that has very high levels of statins in it, right? And then we have a second one who had a statin exposure from taking dietary supplements. It's killing me. Do you remember? Sorry? Well, red yeast rice has it, but the type of mushroom, oyster mushrooms, thank you very much. Oyster mushrooms, there's a couple other ones, have very high levels of statins. In fact, I sort of did a little investigation where I figured out, well, how much of it, because oyster mushrooms are used to cook with, right? So in a single serving of just like your typical mushroom soup recipe, there's over 100 milligrams of statin, which is more than would be in a pill that you get from your doctor. So it's possible that people get dietary exposure. In fact, in China, hardly anyone with anti-HMGCR has been prescribed a statin, but they do tons of cooking with mushrooms, right? And so maybe they just get it from somewhere else.
Wow.
I forgot where I started off, how I got there. But
If I have an anti-SRP
Yeah.
antibody.
oh yeah, the trigger.
Can I pass that on to my children?
No, not as far as we know.
It's
We
something
have
you
not
develop. It's
ever
not something
seen a
that's
case.
passed on. That's
We've
what
never
I'm
seen
saying.
two SRPs in the same family. We've never seen two HMGCRs in the same family. When we see any kind of two myositis in the same family, our radar is up like this is genetic muscle disease until proven otherwise. There may be rare exceptions, right? But usually they don't run fast. Now what we do see is, boy, I've got myositis and my sister has lupus and my mom has rheumatoid arthritis. So that situation is fairly common. There's probably some genetics that make you susceptible to getting autoimmune diseases. But, there are bigger things to worry about, I think, than, because the chances are so low and we don't understand it. It's like hypertension and heart disease and diabetes, all these things, run in families.
But there would be no reason to have my children tested to
Tested,
see if they
they're-
have an antibody now that
No.
they would have gotten from me. 'Cause they
No,
wouldn't.
no, you can't get an antibody from
No,
somebody,
develop.
except you can from when you're in utero, right? So there are some antibodies that cross the barrier, the placental barrier. So there's one in patients who have lupus where the babies can have conduction block from antibodies that they get from their mother. But that's super rare. And we don't see that in myositis.
Okay.
So we had moms who have active dermatomyositis and things like that who give birth to babies. None of them have ever developed any manifestations of the disease.
How long has the disease been around? Is it the 20s? Could my grandfather have had a...
Oh, that's a good question.
What was it called back then?
So back then, it might have been called myositis. It might have been called genetic muscle disease. People might just not have known what it is.
Right.
But, and the spectrum, actually, here's another thing, so sort of food for thought. When I went to the NIH, a previous fellow of mine had already been there. He's working in a pediatric genetic muscle disease group. He's working with them. And they were sent a patient who was 13 years old, and he had slowly progressive muscle weakness since he was about 8. And you looked at his muscle biopsy, there's some necrosis. It looked like the dystrophy, and his CKs were very high. It looked like he had genetic muscle disease. He had all of the usual genetic testing for dystrophy, and was negative. So he's being sent to the NIH to do whole genome and whole exome sequencing to figure out what the gene defect was. This guy, Payan Mohassel, who's my fellow, looked at the muscle biopsy size and he was like, this looks kind of like these HMGCR cases I saw with you when I was at Hopkins. And so I said, well, you should test him for HMGCR autoantibodies. So before he came to the clinic to see us, we sent him a prescription to have him tested. And we got the result back. He was positive before he actually came. And he came with his family. His family was resigned to the fact that he had a dystrophy and was never going to get better. They expected no treatment. He couldn't get up off of a bed by himself. He was really pretty weak. And so we said, look, we don't know. We've never treated a kid with this before. And I have to tell you that younger people don't do as well, so I don't know what's going to happen. His CK was 8,000. We gave him IVIG, and 3 months later, his CK was 700, and he was walking, had no discernible weakness. And 8 months after that, he was captain of his football team.
Wow.
So that was like, wow. And that kid would have been just genetic muscle disease, for sure, even 3 years ago. And we found about 7 more now since then. And we think that there's a large population, a relatively large population of kids who are walking around with diagnosis of genetic muscle disease where they haven't identified the gene, where they could have HMGCR. They could just as easily have SRP. So the spectrum of the disease is sort of expanded a bit for us. So we now think kids can get it too, and that many of them, and then in adults, it can be sort of an explosive thing, especially SRP, people can just crash, where it is in kids with HMGCR, it can be very slow, steady decline, and they just look like they have a slow genetic muscle disease. But they're treatable. Yeah. Oh. What? No, go ahead.
Andrew, in your research, are you looking at checking the heavy metal content in cells?
The heavy metal content?
Yeah.
We haven't checked for like heavy metals in the cells. We've looked in, we haven't, but other people have looked in blood. But as far as I know, nobody's looked in like muscle cells for heavy metals. Is there any reason why you think we should look?
With vaccination,
Oh.
with aluminum, for example.
Yeah.
something
So we don't know. We don't have any we've never really tied it to vaccination, but I'll tell you, my ears are open when people tell me that they think something triggered it now. Like you heard, I've had this experience with the mushrooms where I was totally wrong about that. And the only reason why we figured out that statins were the trigger for this was because our patients kept telling us that they thought that it had to do with statins. And at first we were like, nah, I don't think so. Everybody's on statins, of course. It doesn't mean anything because so many people are on statins. But we checked, of our patients over the age of 60, 97% had been on a statin, whereas only about 30% of the general population had been on a statin at that age. Between age of 50 and 60, it's about 90% who are on statins, and under the age of 50, it goes way down. So it depends how old you are, what the chance is that it was statin triggered. But the disease, back to your question, this HMGCR disease has probably been around forever, right? People have probably always gotten it, but now that there are statins out there, we're just seeing more of it, and more of it in older people, because now 30% of people are exposed to the trigger, or one of the triggering factors, right? So I think that's why we're seeing so much more of it in the older population. It was probably always there, but the trigger wasn't there very much. Yeah.
I'd like to second knowing more about the heavy metals,
Yeah.
because I have 2 prosthetic hips
Yeah.
and metal prosthetics, and I have high metal content, and my disease appeared within about a year and a half of the last surgery, and I was very concerned that one caused the other.
Yeah, so checking heavy metals would be interesting. The way to do it would be to check heavy metals in everybody who's got this disease and compare it to the general population and things like that. That would be the way to do it. Here's an interesting thing for the dermatomyositis people. Dogs get dermatomyositis. Shelties get dermatomyositis. And rabies shots trigger it. It's like the vets know this. And they do it anyway. But it's interesting. So there's in that dog, there's a known, it's not published, but it's kind of just common knowledge, and the vets that I know have seen who treat these dogs is like stressful things cause it. They have colonies of these dogs, and things that stress the colony make the dogs flare, and also definitely the rabies virus, they tell me, does it. So I don't see why it would be different in humans, that there wouldn't be things that trigger it. I'm a believer in the stress thing. Yes?
Yeah, my question is, all through the workshop, there's a lot of talk about how to taper prednisone.
Yep.
My question is, with IVIG, do you just go cold turkey, or how do you do it? How do you get off?
So here's what I'd say about IVIG and HMGCR, or whatever medication, rituximab or whatever. Most HMGCR patients require long-term immunosuppression. Most don't tolerate coming completely off. Out of 100 and some, I think we have 2 or 3 that have gotten completely off, and they had pretty mild disease to begin with. Most people require chronic treatment for anti-HMGCR, but that doesn't mean I always keep at the same level of IVIG. So what I do, and this is not the right answer, this is just what I do, is I taper the dose down. So let's say you get it once for 5 days every month, I'll go to like 4 days. And I'll go to 3 days if you can tolerate it. But that's after everything is stone cold normal. I'm not tapering anything while people are still getting better. In your case, the bigger question in my mind is, is there something that needs to be added? Yeah. And then another question is, well, can I switch from IVIG to something else like methotrexate? So I have one guy who I'm treating with methotrexate every single week, and every few months he seems to need IVIG. Like he's, we give him the IVIG, he comes down, just got him methotrexate, and then things start heading south, so we give him IVIG again.
Is he on prednisone also?
No. But again, everybody's different.
So I was diagnosed in 2007.
Yep.
And started with the prednisone, did do nothing, and actually.
SRP?
Sorry, neither, I'm in the everyone else.
Okay, so then it makes it less clear to me.
Okay.
Yeah.
So in other words, I should.
No, you can ask me, but I may have less of a good answer.
So I know that there are clinical tests being done for like IBM and then DM and PM.
Yep.
Is there anything being looked at from, because my doctor tells me that until there is future developments with stem cell research, it's unlikely I'm going to improve my muscle until something comes along the line with stem cell research. Is there anything down the line that you know of?
So what I'd say is people are only just now starting to do clinical trials that are focused down on narrow patient populations. So like in the past what they do, like for the rituximab trial, is they take 200 patients out of every single kind of myositis under the sun. Some had dermatomyositis, some had polymyositis, and treated them all with rituximab. And the problem is that they probably have 10 different diseases. And some of them are going to respond, some of them are not going to respond, so it's very hard to sort out. Just now are people starting to do focused trials on specific patient populations. So we're working on doing a trial for IVIG as monotherapy. But it's also hard to do that trial because we have to do a placebo-controlled IVIG trial where like you're going to walk in the door and I'm going to say, you've got new onset, anti-HMGCR myopathy. We really want to enroll you in this trial, and we're going to either give you IVIG or placebo. And you're going to be like, well, what if I don't join the trial? Oh, then I'll give you IVIG. So it's a tough sell. Yet we'll never know. So I don't know what the right answer is. Some people, there are 10 like all of us here at this Myositis conference have been involved in this conversation. Should we design this trial? And we cannot figure out how to do it in a way that satisfies everyone, that is both ethical and will give us an answer. Like the most likely to give us an answer is sort of the least ethical, and the most ethical won't give us an answer. So it's really difficult to design a trial, and there are so few patients that have it, you can't do very many trials. The other trial that we're interested in, that I'm going to do at the NIH, is for patients who have bad disease who are not responding to any treatment. So we have some young HMGCR patients who are not responding to anything. We would really like to give them a new class of medications. These are complement inhibitors. So it turns out we think that the antibody, there's something called complement-mediated cell death, where antibody binds to the muscle fiber. In this case, we think it's the HMGCR antibody. And then this complement forms a complex that makes a pore or a hole in the muscle fiber and kills it. This is how a lot of diseases work. And there are these complement inhibitors that block the complement pathway that help other diseases that are complement mediated. So let's use these drugs. They're available. Like, why don't I prescribe it to you tomorrow? Well, there's no approval for it. And B, it costs, for us to do 2 months of treatment just for the medication will be $75,000. It's going to cost $130,000 in medication for us to do.
That's not
Like
the
a-
IVIG though, isn't it?
It's even more expensive than IVIG. Well, it's really expensive, let me put it that way. So we're going to take a couple patients, and the NIH is just going to pay for the drug. And so we're going to use it in a couple of the very severe people, and then we're going to hope to leverage that to get the company to support an actual trial of it for people who have, pretty severe disease who aren't getting better. But these are difficult trials to do. Yes.
In your opinion, do you think anti-SRP patients can be tapered off of their medications?
So, SRP, it's highly variable. I do have a few, I have one patient who's SRP positive, who's not on any medications. Her CK is like 4,000, but she has a necrotizing muscle biopsy, but she's not weak at all, and she's never been weak. You've actually never treated her. I worry about her, but she doesn't have any fatty replacement on her MRI, and she just goes along. I don't know what's going to happen. And I'm trying to think, I have tried to take other SRP patients off. I've gotten people way down, so just on like one medication. I take it back. I do have an SRP patient who has now been off for like 2 years. She had severe disease. She was on rituximab for years. She had a baby, and when she got pregnant, we took her off everything. And she has not needed it for a couple of years now, even after the pregnancy. So yes, I do have, and maybe my colleagues have others, but I can at least speak to one pretty severe SRP patient who required intensive therapy to get it under control, who's now off of everything.
I successfully tapered off the prednisone after a very long time.
Yeah.
Like 5 years, but I still take Cellcept.
Yeah.
But I'm still weak, I still have symptoms.
Is your CK still elevated?
200 to 300,
Yeah.
just kind of where it's been for a couple years.
Yeah.
But I don't tolerate the side effects of the prednisone well. It's
Yeah. Prednisone's not a good player long term.
miserable.
Yeah.
But
It's
on the
tough.
Cellcept,
I don't know
feel
what-
great.
So I don't know what to do. That's a tough call. Most people like you that I take care of don't want to come off their Cellcept. They're like
I don't
not
really want
willing.
to.
They're not willing to try it.
I worry
And I
about-
think that's a
yeah.
reasonable choice.
Okay.
Yeah.
I worry about the risk of lymphoma and things like that, like everybody does.
Yeah.
And then I look at the long-term picture, and I'm functioning, I'm working, I'm
So
feeling
the
good.
thing to work, I have seen this. So I had one anti-SRP patient who needed GI surgery. I didn't know about it. The surgeons took her off of. She was an azathioprine, I think, and she'd been doing pretty well, disease stable. They took her off of it for like a couple of, like just cold turkey, took her off of it, and then they had her off of it for a few months, maybe 3 or 4 months even before I saw her back in my clinic, and she showed up and she's like rolling in a wheelchair, and her CK is way up, and I've never been able to get her back under control, despite rituximab, high dose steroids, back on the other, so the one thing is slow.
Yeah,
So if I were taking care of somebody who was on like 6 pills of Cellcept a day, and you were doing great and I was gonna taper it, I'd lose 1 pill every 6 months at the most. I do the taper over a year. I'm not even saying you should do it,
No,
but if
is
I
there
were
any
going to do
reason-
it, I would do it very slow.
If you're kind of cruising along and feeling good and able to work and healthy.
It's the side effect thing to worry about.
Yeah.
It's not totally benign, even though you
Sure.
tolerated it really well.
Sure.
So different people have different tolerance for risk.
Like the stock market.
It's like the IV. Well, no, it's true. It's like that's why everything. That's part of the no right answer for everybody, because like the IBM patients. There's no treatment that's been shown to work, but I might say I've seen like one patient who I think really did respond. Maybe it's 1%, and I'll explain to patients. Look, there's a 1% chance that the medication's going to work. I'm not even sure about that. Never been proven to work. Here's the side effect profile. Patient right here will say, why in the world would I take any medication that's never been shown to work that has that side effect profile. Why? That's crazy. Why would I do that? The person right next to them will say, I don't care about the side effects. If there's any chance it's going to work, I want to take it. Right? So ultimately, patients have to decide. Yeah, because they have different tolerance for that. Yes.
They had a focus group here on sub-Q versus IVIG. I mean, it's exactly the same, right? Just a different route of administration.
It's not exactly the
Right,
same.
maybe it's
It's very, the one thing I would say is different. So what I would say is that it's the same IVIG, it's the same immunoglobulin. The only difference, like you get an IVIG, you get it intravenous versus subcutaneous. There is a peak of IVIG that you get when you get it intravenously that you don't get when you take it sub-Q. But we don't know that that's important.
They seem to think that it was better since
It may be, right, it may be better. It may be, my point is not that it's, my only point is it's not exactly the same. So it may be better, or maybe not as good. I think it's probably the same. Like in my experience, my limited experience, I have like one patient who we switched from IVIG to subcutaneous, and she does just as well on the subcutaneous as she did on the IV. But that's why these guys are doing, they're doing trials. So in some things, it's been shown to work just as well. So what I'm saying is just for myositis. Yeah.
Can you give me a research article or something that I can show to our doctor to support IVIG alone?
Yes. So New England Journal of Medicine. I'm the author. It's a letter. There's a letter in there. It's IVIG as monotherapy for anti-HMGCR. And 2015, 2016.
Thank you.
Yeah. And not everybody has my approach. So you can talk to really smart, experienced people who will say, no, we ought to give everybody steroids first. So we don't know what the optimal thing is, but I think it works for most people. It may not, I don't know whether it's the optimum, I don't know if it's the only thing that works. Some people, rituximab is what's used, and that seems to work really well. I tend to use rituximab in people who don't respond to IVIG super well.
HMGCR patients?
Yeah. And then I have other patients who are on methotrexate or Cellcept and nothing else who do well. So, but I feel like that at the beginning of the disease, what I personally like to use first to get the disease under control is IVIG. I'm not opposed to people adding other things, but I would like to see IVIG as part of it. Or early on, like go ahead, use your steroids and methotrexate, and if that works in 3 months, terrific, more power to you. But boy, I would not wait a year to add IVIG.
Well, yeah, I mean, Stephen, as soon as he was diagnosed, we went for that one, but he's probably had the disease a while.
Yeah.
Undiagnosed.
Yeah, that's the typical thing, that people have had it for a while. So I'm biased because I like that, I want to do a trial on it. But if it's not working, then you do want to move on to another strategy. Mine would be to add something, because I do feel like if your CK has gone down to a third of what it was, I feel like you're moving in the right direction, but maybe you need something additional. And then there's a whole other story about, do I have to stay on IVIG forever, or can I switch to another drug? That's all trial and error also. I saw you had
Yes, have you seen whether or not IVIG could have any impact on calcinosis, or if there are any other treatments that...
Yeah, calcinosis, I hate calcinosis.
We do too.
I hate it. I hate it. And it's because I feel powerless often. And I hate that feeling of patients coming to me and me not being able to tell them what's going to make them better. Some of my worst calcinosis have been in patients who had dermatomyositis. I've got them totally under control. Everything is like great. I feel like I've done a great job. Everyone's happy. And then out of the blue, calcinosis starts coming. And so I add IVIG and I add rituximab. And so I hear what people are saying, and I'm all for I would try all kinds of things like IVIG and high dose steroids if need be, and I would try other things, but we don't know what it is. that is driving that whole process. And sometimes even the most aggressive treatment, it does not get it under good control. I really, the reason I hate it is that I don't have a good answer for your question. The NIH is super interested in it. There's a group that's doing, that's going to be doing a clinical trial for an infusible medication for calcinosis. So this guy, Adam Schiffenbauer at the NIH is going to be starting. It hasn't started yet, but they think it's going to start pretty soon. So that's something to potentially look into. They'd actually bring you in, and I think they keep you in the hospital for like 8 weeks or something like that to give you these. It's something. It's serious. But NIH is free, so it's something to look into. Again, I don't know that drug is going to work or not, but it may. Fortunately, for the rest of you guys, calcinosis, not a thing in HMGCR and anti-SRP.
What is the thing?
So you're in a way, you're pretty lucky compared to other type patients with myositis and inclusion body myositis, because for almost every, SRP is a little bit less this way, but for HMGCR, it seems to really only affect the skeletal muscle. So people don't get arthritis, they don't get interstitial lung disease, they don't seem to be at a particularly increased risk of cancer. SRP, there is some interstitial lung disease and some other stuff, but still very low prevalence and usually low severity compared to patients with other types of myositis. So
What about heart muscle or dysphagia?
dysphagia, yes, but not heart as far as we know. Again, we've never taken 100 HMGCR patients and put them in an MRI scanner to look at their cardiac muscle, which is what you'd have to do, I think, to figure this out. But cardiac has not been a problem in our HMGCR patients. And that's pretty true for the SRP patients too.
What about cholesterol levels? Just beans and rice forever?
So this is an ongoing thing. So most of my patients wouldn't go back to a statin if I paid them large sums of money. You know, even if and once the disease is under control. So we have not retreated a lot of people because most of the people went on it not because they had a heart attack or stroke and need it for like secondary prevention. Most people were taking it for primary prevention to reduce the risk of something. So most people are like, you know, forget about it. But we do have some people who had strokes or heart attacks, have crazy high cholesterol levels. And so a few of those people we've treated, we've let them go back on low dose statins. I don't have like hard data on this, but usually we have to really continue to immunosuppress those people hard because it's like they keep the trigger still there. These new medications, the PCSK9 inhibitors, we have I have 2 or 3 patients who have just started it in the past couple months who are well-controlled anti-HMGCR positive patients, and we'll see. We don't have any information on it. There's reason to think that it may be not a problem, but we don't know.
And those are approved, right?
The PCSK9 inhibitors are approved. They're expensive injectable drugs, but they work really well. And we just don't know whether they will trigger this disease or not. You can also email me about the IVIG thing. Like if insurance companies don't want to pay for it or something, I have like a whole packet that I send them.
How can you email you?
Andrew.mammen@nih.gov.
Thank you.
Sure. Any other questions?
Maybe a crazy question.
No.
Sorry.
No, believe me, there aren't crazy questions. It's really true that we learn a lot from listening to the questions of our patients, because they always think of things we don't.
So, what could be the situation if we use a plasmatic exchange?
Plasma exchange.
Once a month, for example, like it's done with cholesterol elimination.
Yeah.
So, because when they did, I have the 6th plasmatic exchange.
Oh, yeah.
After that, I was really feel really better.
Yeah.
So we remove all the antibodies, but also the autoantibodies,
Yeah.
which is our enemy.
Yeah.
So why not?
So he's asking, you guys may not know about this treatment. So plasma exchange is where you put like a catheter in one vein and the blood goes out. It goes through a machine that takes out all the antibodies, all the immunoglobulin and some other stuff. And then the blood runs back into you. And you usually undergo like 5 of these plasma exchanges over 10 days or something like that. It is an effective treatment for other antibody-mediated diseases. And in France, Olivier and his buddies use that in severe cases of myositis, including HMGCR and such. We don't do very much of it in the United States for myositis, but I have used it in a few very severe anti-HMGCR cases where everything else was failing. And I do think it works a little. It does work a bit. Usually the problem is you've got people, my patients who I put on it are my most severe cases. So they're on like 3 immunosuppressive drugs, and then I'm starting to put catheters in them. And they're not, and I pointed to my vein like it was an IV, but these are central catheters, central line catheters that they put in. And so the first patient I did, she felt...
Do you have the 2 central lines? Because one to take
You
out?
can have a double lumen one.
Oh, okay.
She went and she got it, and she did feel better. Her CK went down. I could actually see that she was stronger, but she went home and got septic and had to come back in the hospital. She was like very ill. I was like, so I was scared away from it for a while. I had one other patient who, these are young, both of them young African American women with anti-HMGCR, severe disease, not responding to treatment. The second one, I gave her IVIG, gave her plasma exchange, and she also felt like she was doing better. A couple of years go by, and she's now really worse, and she's like on the verge of going in a wheelchair. I've tried everything with her, and so I said we could put in permanent catheters, like 2 catheters, one here and in and out, and we could just bring you in and plex you, and then plex you like twice a week, indefinitely, and see what happens. And she has stabilized and gotten a little bit better. It's not a cure for her disease. She has a lot of permanent damage, but she has stabilized and gotten a little bit better. But I worry about her every day because she's on other immunosuppressive medications, and I feel like it's just a matter of time before one of these things gets infected, and I have to pull it out. So that's so I do think it works. I do think it probably works, but I think that it's a big deal to go through it, especially if you need it chronic. And again, I'm not totally rogue doing this. There are severe. The reason I thought of doing it is because there are patients with severe myasthenia gravis, which is another autoimmune disease where it's an antibody-mediated thing, and some of their severe patients require plasma exchange, like chronic plasma exchange.
Is
But
it the same as pheresis?
it's the same as pheresis. But what I don't know, and this is maybe getting more to your question, is maybe when I saw you, what I should do is like give you Plex and then start up IVIG. Like get rid of the antibodies and then give you the IVIG. What you don't want to do though is give people IVIG and then Plex them, because then you put in like $30,000 worth of IVIG and then you just take it back out. I've seen people do it. Question?
So plasma exchange is similar to chelation?
No.
No?
Chelation is different.
Okay.
Chelation is usually where you're trying to, you're adding something to the blood to try to pull something else out.
Okay.
Yeah, so the chelation therapy, the one that I would be most familiar with, is chelation therapy that's done for lead poisoning, for example, like trying to get the lead out of the bloodstream. So you put in a chelator and it binds to the lead and gets rid of it.
Okay.
But that's different. Yeah.
Do they accept your very expensive product? Are you looking for other product, something like that?
You mean like other things that do the same thing but that are less expensive?
70,000.
Yeah. So all of the diseases that treat with this are really rare diseases, which I think is part of the reason why it's so expensive. But I would imagine none of these drugs stay super expensive forever. We're going to find out whether it works. I mean, for these patients, I do whatever I could to try to get that drug if it works. The first thing to do is just figure out whether it works or not. But most people are not. The good news is most patients with necrotizing myopathy don't go down that pathway. Most of them, we actually get better. So, HMGCR patients and SRP patients, most of them, we can get a lot better. And the key thing is early and aggressive treatment. It's when we let people get really, really, really weak that it's then harder to bring them back. Of course, HMGCR we didn't know about, so it was, until recently, so it was, a lot of people had it for a long time before getting treated. Bob, how are we doing?
Continue, I just.
Good, okay. Thought I might be in trouble, it's like the principal walking in the hall. Yeah,
I was glad that I had the IVIG solely by itself.
Yep.
And had the success with that without a steroid
yeah,
to confuse the effect.
yeah.
But now wondering about adding that on and whether that will be inconsequential or the benefit of taking that extra step.
Yeah, it's a good question. It may make it harder to know whether the IVIG is working. Yeah, I mean, you're thinking about it in exactly the right way. Those are the kind of questions that we have to ask ourselves. But at the end of the day, if something's not working, if it's clearly not working, you just have to add something else. It may or may not be steroids is the thing to do, but.
Would there be a criteria for selecting the steroid rituximab versus prednisone?
So, I think that it's hard for me to answer that without knowing, like seeing you and like getting the whole story and examining you and knowing everything about you. I don't have a one-size-fits-all answer to that question. Yeah. Any other questions?
Well,
Yeah, please. Yeah, go ahead.
This may not be a kosher thing to ask, but has anybody sued the statin companies for anti-HMGCR?
People ask me about suing them. But I don't think anyone successfully sued them over this. People have tried to sue their doctors also. Usually they're going after the doctor because the story will be, I kept telling my doctor that I was weak and feeling bad, and I said, is it the statin? And they kept saying no, and yet it is the statin. So usually they're not going after the drug companies, usually they're going after the doctors. But I don't know that anyone, I don't know how successful people have been with that.
This was a series of statins, like, well, this one's not working, your CK is going up, let's give you another one, so he's been through like 5 years.
That would have been the thing to do. 5 years ago or whatever, that's what people would have done. Usually would have waited for people's CK to go back down, before starting another one. But
They waited for it to go down some, but
Yeah.
not back to normal.
yeah, but it's a very new disease. I mean, even still, a lot of people don't know about it.
That's the segue to my question.
Yeah.
All right, so my daughter's 23. We think it's polymyositis. Colin Ligon is her physician at UPenn. We're still waiting for the muscle biopsy. So if it turns out that it's necrotizing myositis, what do I do next? She's only been on meds for about 5 weeks at this point.
So, again, everybody is a little bit different.
Yeah.
What I really want to know about people is not what their muscle biopsy looks like. What I really want to know about people is what is their autoantibody.
Yeah.
The muscle biopsy is helpful, but to really, for me to know exactly what disease people have, I like to know that. Yeah.
So we know she's not anti-Jo1 positive. Would it have been typical at a medical center like UPenn to have done the whole thing?
No, I can't answer that question. It is a complicated question because there are panels that are easy to get done that aren't that good, and they come back quickly. And then there are panels that are highly reliable but are tricky to get done because they're out of state. And this is like a regulatory thing. Oklahoma, that's the man.
We got turned down.
OMRF, that is that for me, that is the gold standard.
Okay, so we gotta find.
But he doesn't do HMGCR. That, if you want to get it commercially, is at RDL, they do it. I used to get money from that, I don't anymore now that I'm a government employee, so, but just still,
Down Baltimore.
yeah. And we do them in the lab, but then those are done on a research basis. But for me, my person, and you know, Rohit was talking about this today on the session. For us, we really want to know what the autoantibody is, because that for us tells a huge amount of the story. Biopsies are helpful too,
So
but
we're next week, so I should push on that.
I like OMRF. But if you can get a myositis panel at RDL as well, which is pretty good, but less perfect. The problem with OMRF is it takes a few months to get the results.
I know, which it should
Yeah.
be done.
Question?
You said for younger patients going forward, you were not as optimistic. You thought the disease progression would be worse. What do you see?
I mean on average. So everybody's different. So like I told you, like young HMGCR patients are most difficult. And yet I had that 13-year-old boy who had a beautiful response to IVIG. So this is, when I talk about that, that's what happens, that's what the averages are. It doesn't mean that's what's gonna happen to you, you know?
So for 35, what would you forecast?
So it's easier. I can only forecast effectively or reliably after I've treated patients really aggressively. So if I treat somebody really aggressively and they don't respond very well, I have a very different story than the same patient who had a very good response to that treatment. So when I first see people, it's very hard. When I first see people like with dermatomyositis, I say, you know, a third of you, when I can treat you, and you won't hardly even know you have the disease, you know, that you ever had it. A third or half, you know, we treat and you get way better, but there's still things there, the disease is still there a little bit. And then there's a smaller percentage where even despite our most aggressive treatment, you're gonna have significant issues with the disease. So, but I don't know when those patients, those dermatomyositis patients, when they walk in the door, I don't necessarily know which group they're gonna fall into. No. But aggressive, for SRP, aggressive treatment, Rituxan is the way to go. Like we treat everybody with Rituxan. Like if you walk in the door and you have SRP, most people we're gonna give you rituximab because we don't wanna wait for a year and have had like significant damage going on before we do it. We didn't always know this, but that's kind of the way we go now. And Rohit does the same thing for JO1 positive patients, it sounds like. Like he knows that JO1 myositis patients respond to rituximab. So again, that's where the antibodies help us. That's not the advice I'd give to the same person who has HMGCR. Yes?
Then what about those of us who don't have any of those autoantibodies?
So I can't answer it. So it means, so I would say I need to better understand what you have, you know? So if you have a necrotizing myopathy, but you don't have HMGs or SRP, then my next question is any other organ system involved? Do you have interstitial lung disease? Do you have joint involvement? Do you have skin involvement? Right, because that means you don't have dermatomyositis or, you know, the usual polymyositis. So then I would say, is there something else that you could have? Could you have a genetic muscle disease? A lot of them are necrotizing. Is there some toxin that you're taking that we don't know about? Like, are you taking colchicine or, you know, who knows what? So we go through a process, and then I'd say, okay, well, I can't think of what else it would be. So it must be autoimmune, especially if it was like one day you were fine and then you had like a sudden decline. And then we would just start treating you and just ramp it up, I usually would just get very, very aggressive. And I'd say, let's just blast away with everything we have and it's either gonna work or it's not. But that's kind of that would be my approach to that. But when there's no antibody and there's no other disease manifestations except for skeletal muscle, then I don't understand it very well. And I worry about genetic. Other questions? Yeah.
if I'm doing well on CellCept, is there any, and functioning, is there any reason to push ahead and ask for the rituximab, or?
I would say not. I would say not.
I'm willing to leave well enough alone because I work as a nurse.
Yeah,
I'm
I would
doing
say not.
CellCept.
I never, if it's not broken, don't fix it. That's kind of would be my rule number one.
I like that rule. I like that rule a lot.
All right. Anybody else? Are we out of time? Yeah, we've been past time. All right. Thank you guys. Oh, one more? No? Good. All right, thank you guys so much for coming. Hope it helped a little bit.
My name is Chris Harris. I have dermatomyositis. I was first diagnosed in 2005. So this is my 12th year, and this is my first year to this meeting, which I'm kicking myself for, but going forward, I'll be at every one. My favorite part of this meeting is meeting the patients and their advocates, and I'm amazed at the support that I've received since I've been here from everybody. And I love that people have shared their stories, no matter how challenging, but I love the idea of hope for everybody. And my second favorite part of this meeting is the individuals who have donated their time to move this disease forward and try to find a cure, which includes everybody with the Myositis Foundation as well as the panel. Every person who has volunteered their time, the physicians, the physical therapists, the volunteers, and the fact that they've committed to do this as they move forward is amazing to me. And I love it, and I will be here again next year and the year after that. And it just gives me a lot of hope when I was very depressed. So thank you for inviting us, thank you for supporting it, and I look forward to seeing everybody next year.
Hello, my name is Anastasia Victorson, and I came here all the way from Stockholm, Sweden. I'm very happy to be here.
Is this your first time coming to the myositis?
To this conference, yes. To the TMA conference the first time.
What's it been like?
It's been fantastic. Very informative. I've met my friends, my Facebook friends, and I hope I'll be able to come again. I have polymyositis, but I also have a syndrome that's called the anti-synthesis syndrome. I have antibodies, a lot of them, but anti-Jo1 is the most common one. And I also have ILD, quite serious. But getting medication, feeling quite okay. The doctor saved my life. Yeah. Very good information. And it's also nice to see the persons. I read a lot. It's also nice to see them in real life, to be able to interact with the doctors. Yes. I'm just happy to be here, having met you too. Take care. And everybody else that hasn't been here, hasn't gotten a chance, please try, because this was really worth it. It's beyond my expectations, really. Thank you.
Hello, my name is Dale Scott. I'm from Pennsylvania, and I'm looking for all the people from Pennsylvania for our kit group, so give me a call.